Welcome to eCrit Podcast. This is our episode number 117, and today I'm joined by my co-host, Dr. Josh Chacko. Welcome, Dr. Chacko.
Good evening, Swapnil. How are you?
I'm good, thank you. It's been a long time since we recorded our last episode. Both of us have taken some time off, which has been quite productive. How's things in India in ICU?
It's as busy as always, but not too bad in the last few days. And the weather has been nice as well. It's cool, occasional rain. So overall, can't complain.
Yeah, no, that's good. So we are also heading into now very hot summer here in Sydney. So hoping there won't be any major natural disasters. Fingers crossed. Let's dive into today's episode. So we decided to do another journal club because there was another very important randomized controlled trial which was published in New England Journal of Medicine. And really, the question we are trying to ask here, and I'm just trying to start with this clinical scenario here, that say 70-year-old male admitted with left MCS stroke in ICU, and this stroke was secondary to rapid AF. And I guess the question always kind of come to the bedside discussions is, when should we start anticoagulation? We know the AF is the risk factor, and we know that that has led to this MCS stroke. So what's the kind of duration? How long should we wait? Which agent should we start? And what to kind of do with this anticoagulation practices? And if you look at some of the literature, it's really interesting. And even if you ask some of the neurologists within the department, they will have slightly differences of opinions or different preferences in order to when to start and what to start with regards to anticoagulation. The current guidelines, and there are kind of two different guidelines, European guidelines and American guidelines. And consensus is you perform your brain imaging on admission and look for any hemorrhagic transformation or not. If there is hemorrhagic transformation, then I guess you just delay commencing the anticoagulation for at least a month. And that's also based upon the clinical improvement and then repeat CT scans and then trying to assess the volume of the hemorrhage. So majority of the guidelines are very consistent in that regards, where there is a hemorrhagic transformation, we do not start anticoagulation for 28 days. Now, if there is no hemorrhagic transformation, and that's really the interesting factor for most of the ICU patients. And in ICU, we do see majority of the patients with severe neurological deficit. And in that kind of setting, usually the guidelines suggest to wait for at least 12 to 14 days if there is a severe neurological deficit. And if it's a moderate persistent neurological deficit, then to wait for 6 to 8 days. Usually after TIAs or with a mild neurological deficit, the anticoagulation can be started within the 3 days. But again, a lot of the time, there is inconsistency or differences of opinion with regards to a duration after which the anticoagulation can be started. And when I say anticoagulation, usually it's about starting the NOAC therapy, which is the novel oral anticoagulation therapy. We have moved away from using warfarin in this context and usually try to lean towards starting NOACs nowadays, especially if there is no contraindication to start one. So, Dr. Chacko, this trial, ELAN Trial, which compared early versus delayed anticoagulation in patients with ischemic stroke after atrial fibrillation, what are the kind of key points in this method and results of this trial?
The trial was conducted across 103 centers in Europe, Middle East, and Asia between 2017 to 2022. In fact, I think there were about 50 patients from various hospitals in India as well. The study aimed to compare the effect of early compared to later initiation of anticoagulation following acute ischemic stroke in patients with atrial fibrillation. Patients were eligible if they suffered from an acute ischemic stroke and had non-valvular atrial fibrillation, persistent, paroxysmal, or diagnosed during hospitalization. Ischemic stroke was confirmed by evidence of acute cerebral infarction on CT or MRI with persisting symptoms for more than 24 hours. The infarct size was classified based on the appearance on imaging into minor, moderate, or major stroke. Minor stroke was defined as infarct size of less than 1.5 centimeters. A moderate stroke was defined as infarct in the distribution of a cortical superficial branch of the middle, anterior, or posterior cerebral artery. And a major stroke involved larger infarcts in the distribution of the same arteries, or a brainstem or cerebellar infarct of more than 1.5 centimeters. Patients who received thrombolysis or underwent mechanical thrombectomy before randomization were also eligible. Therapeutic anticoagulation at the onset of stroke was not allowed. DVT prophylaxis was allowed. Who did they exclude? They excluded patients with prosthetic valves, patients with moderate to severe mitral stenosis, patients with other indications for anticoagulation, patients who had therapeutic anticoagulation baseline, any serious bleeding in the past 6 months, or patients with a high risk of bleeding were excluded. Severe renal impairment was an exclusion criterion, and so was intraparenchymal bleed. So what were the study groups? Patients were randomized to early or later initiation of direct-acting oral anticoagulants, or DOACs, in a 1-to-1 ratio. Randomization was stratified based on age, 70 years or more, infarct size, like I mentioned previously, minor, moderate, or major, the NIHSS score of 10 or more, and trial site. Earlier and later treatment were defined as early treatment was DOACs commenced within 48 hours of symptom onset in minor or moderate stroke. In major stroke, treatment was commenced on day 6 or 7 in the early treatment group. In the late treatment group, DOACs was commenced on day 3 or 4 for minor stroke, day 6 or 7 in moderate stroke, and day 12, 13, or 14 in major stroke. Both groups received stroke treatment according to local protocols. The choice of the DOAC was left to the treating clinician. And the study used a fairly novel statistical methodology in that at the time of commencement of the trial, which was sometime in 2013-14, no unbiased data was available to form a hypothesis regarding potential superiority or non-inferiority margin between early compared to later treatment. Hence, no hypothesis-based testing was carried out, as is usually done with randomized controlled trials. The authors aimed only to provide ranges for outcome differences between trial groups based on the confidence intervals. The results were meant solely to provide qualitative data to clinicians and guide them. Sample size calculation was entirely based on the expected width of the confidence interval. A sample size of 1,802 patients was calculated based on the primary outcome event of 5% in the later and 4.5% in the early treatment group, with 95% confidence interval width of at least 2 percentage points. The authors plan to enroll 2,000 patients, allowing for missing outcome data. So what were the findings of the study? Overall, 2,032 patients were randomized. Full data was available for 2,013 patients, 1,006 in the early and 1,007 in the late treatment arm. Baseline characteristics were similar in both groups. The median age was 70 years. Nearly 40% of patients had a minor stroke. Another 40% had a moderate stroke. 20% suffered a major stroke. Thrombolysis was carried out in approximately 40%, and 20% of patients underwent mechanical thrombectomy. What was the primary outcome? The primary outcome was a composite of recurrent ischemic stroke, symptomatic intracranial hemorrhage, major external bleeding, systemic embolism, and vascular death at 30 plus or minus 3 days after randomization. It was a composite outcome of all these that I mentioned. The primary outcome event was lower in the early compared with the later treatment group, 2.9% versus 4.1%, a difference of 1.2 percentage points in absolute terms. The odds ratio of a primary outcome event in the early versus the later treatment group was 0.7 in favor of early treatment, with a 95% confidence interval of 0.44 to 1.14. So this actually corresponded to a range that lies between a reduction by approximately 2.8 percentage points to an increase by 0.5 percentage points in the risk of a primary outcome event. So the components of the primary outcome at 30 days included, as mentioned, recurrent ischemic stroke, 1.4% in the early arm and 2.5% in the late arm. So difference of 1.1% in terms of absolute percentage points. So that was the main driver of the primary outcome in terms of the recurrent ischemic stroke. Systemic embolism was also lower in the early treatment arm, 0.4% versus 0.9%. Vascular death was similar. Most interestingly, symptomatic intracranial bleed was very few in both arms, almost 2 out of 1,000 in both groups, corresponding to 0.2% in both the arms. So it was very low, and there was no real difference between early and late treatment arms. Major extracranial bleed was also very similar between the two groups, 0.3% in the early versus 0.5% in the late arm. The secondary outcomes were the same outcomes at 90 days instead of 30. 30, of course, was the primary outcome. So the composite outcome at 90 days occurred in 3.7% in the early compared with 5.6% in the late group. Again, numerically better in the early treatment arm. Recurrent ischemic events were lower in the early group. Other outcomes were similar between the two groups. And when it came to the neurological outcome in terms of the score on the modified Rankin scale, the score ranging from 0 to 2. 0 to 2 means up to the point when patients are able to take care of their own affairs without assistance. So up to 2 were nearly equal between the two groups, approximately 66% in both the groups. So to conclude, the study employed an image-based classification of the severity of stroke into minor, moderate, or severe to decide on the timing of anticoagulation for atrial fibrillation. Based on this classification, the incidence of the composite outcome of recurrent stroke, systemic embolism, hemorrhage, or death at 30 days was in the range from 2.8 percentage points lower to 0.5 percentage points higher with the early use of DOACs compared to later use. There was no increased risk of bleeding with the early use of DOACs. The study supports the early use of DOACs following acute ischemic stroke in patients with atrial fibrillation and suggests that early anticoagulation may be better and unlikely to cause harm, even though, as I mentioned, they did not perform this study to come to a definitive conclusion in terms of superiority or even non-inferiority.
Thanks, Dr. Chakos. So I guess this trial is a landmark trial for many reasons. First and foremost, this is probably the largest randomized controlled trial performed on this topic. It was conducted as a multi-center trial across 103 sites and around 15 countries. So the external validity of the trial is really, really good. Now, the key limitations of this trial, as you rightly mentioned, the first and foremost itself is open label trial, which has got issues with its non-able to blinding and bias associated with not blinding. The second one is obviously the primary outcome is the composite outcome, and is really, really makes things really difficult to interpret because the trial was not powered to one particular outcome. Instead, it was a composite outcome, which is very challenging. And I guess the how you define early versus late commencement of anticoagulation has varied across different trials in the past. So when you try to combine the data of different trials to perform systematic review and meta-analysis, it always a little bit gets problematic because every trial has used different definition of early versus late. Nonetheless, this trial has given us a very clear signal with regards to when should we start anticoagulation. Now, this is very important from our current setting point of view because majority of the time even commencing the DVT prophylaxis can be a challenge and needs a lot of negotiation between the specialties. While this trial was quite useful in that regards, because every single patient in this trial did receive a DVT prophylaxis. And in addition, they either were randomized to receiving early DOACs versus late DOACs. So this trial has definitely given us a much more information and the data around this topic. The outcome difference is quite relevant because many people like to sit on the fence and not to do anything with these patients. But in fact, now there is some signal that with early commencement of anticoagulation, there might be some benefit with regards to recurrent ischemic strokes or embolism. And also the risk of bleeding is not as significant as we used to think about in the past. So overall, well done trial. And again, largest randomized controlled trial on this topic, which gave us some answers on this topic. Now, just to put this trial into perspective, there have been 4 other trials which were conducted on the same topic. The RS trial, which was done in 2021, included only 91 patients. And in that trial, the early initiation of apixaban was based on the stroke size, and the primary outcome was again composite outcome of fatal stroke, recurrent stroke, or TIA. And it was actually similar between the two groups. So there was no difference between the early versus late commencement of anticoagulation. Asymptomatic hemorrhagic transformation was actually not lower in the apixaban compared to warfarin. So I guess that trial also showed that probably apixaban is equally effective as warfarin, and it does not lead to more hemorrhagic transformation. Now, the RS trial was ended prematurely because the national guidelines changed the recommendation in favor of direct oral anticoagulation over warfarin. And I think that's an important shift last decade or so, where we are turning away from the warfarin and using DOACs more. So that was the first trial. Then there was a timing trial, which was conducted in 2022, has got 888 patients with acute ischemic stroke within the 72 hours with AF. And early was defined in that trial as a less than 4 days, versus late anticoagulation commencement was defined as 5 to 10 days. Now, the primary outcome was again composite outcome of new ischemic stroke, ICH, or all-cause mortality. And that was significantly different in favor of early anticoagulation start. So combining timing trial result, arrest trial results, and this trial results, I think it kind of helps to kind of put the whole thing in perspective that early commencement of anticoagulation is actually beneficial in this cohort of patients. Now, there is another trial called the Optimus trial, where the patient with acute ischemic stroke and atrial fibrillation were enrolled, and early, which is less than 4 days of, or 7 to 14 days initiation of anticoagulation after acute ischemic stroke was tested. And I guess this trial is still running. We do not have the full results of this trial, and hopefully that will add to our information and help us to make a kind of clear sense of this data that is currently available at the moment. So this trial will force me to think a little bit more about my own practices. What's your take on this trial, Dr. Jaco?
Yes, Swapnil, I think it's a very important trial because usually we do hesitate to commence anticoagulation in patients with stroke, especially those who have a major infarct, given the possibility of bleed, which can result in a catastrophic outcome. So this trial gives physicians the confidence that early treatment within the first 48 hours, minor or moderate stroke, less than 1.5 centimeters or correspondingly small, would probably not result in an increased incidence of hemorrhage to begin with. And also, from whatever conclusions that we can draw out of this study, there may be an advantage in terms of a reduction in the incidence of recurrent ischemic stroke, which is, of course, a major concern with atrial fibrillation. Many of these strokes are, of course, from emboli, which you may not readily see on the echocardiography at the time. But presumably, most of these strokes arise from emboli, and early anticoagulation clearly would be of benefit. Had it not been for the fear of bleed, we would have, of course, been doing this even previously. But now, of course, we have this study that supports early anticoagulation in patients with atrial fibrillation. The study had a few limitations, which included One of the facts, of course, there was no wide distribution apart from some patients in Asia, including India and the Middle East. Apart from that, most of the patients were confined to Europe, and hence validation in other ethnic groups which with a lower incidence of, perhaps a lower incidence of recurrent ischemic strokes may not be robust enough in this particular trial. They excluded patients with any parenchymal hemorrhage. In that subgroup, of course, you would hesitate to start anticoagulation anyway. And many have argued that the stroke severity of this whole cohort was low based on the NIHSS score compared to previous studies. So that itself may be a limitation of the study. And of course, finally, the study was not defined to test superiority or non-inferiority. So it can only offer guidance to clinicians. And that was the only aim behind the study, to present data and give a rough confidence interval and offer guidance, not in terms of providing robust conclusions. But overall, it's an important question. And hopefully, with the Optimus trial ongoing, the results are expected to be out around a year from now. We will hopefully be more knowledgeable in terms of the optimal time to start anticoagulation among patients with atrial fibrillation and ischemic stroke.
Yeah, that's really important. And with regards to AF, I always feel that it's like we're chasing the tail, or it's like a chicken and egg concept. Because if we don't cardiovert the patient in rapid AF, the risk of embolic stroke is going to be always high. But in order to achieve the cardioversion, you need to obviously anticoagulate the patient. And in this particular subgroup of patients, that has been the major problem in the past, because people were quite reluctant to anticoagulate, as you said, with a significant amount of penumbra or ischemic infarcts. So with this trial, probably those practices will change, and patients will be probably on DOACs early, and then they will be considered for cardioversion if they do remain in rapid AF despite all the best effort to cardiovert either chemically or rate control AF. So this trial has definitely give us that information that we can potentially use anticoagulation in the subgroup of patients. So yes, it's definitely going to change my practice in terms of if I get a patient with MCS stroke, starting the DVT prophylaxis is definitely yes. Now starting the NOAC therapy in that particular subset of patient, you still need to obviously liaise with neurologists, understand the pathology, understand how big is the infarct, and also having that ongoing discussion every single day. When can we start the anticoagulation in this patient? So just not to assume blindly that we're not going to start anything till 28 days. I think that's not the right approach. The right approach is to evaluate daily, see the clinical progress, and then don't be afraid or don't be too concerned about starting the NOAC therapy or DOAC therapy in these patients for 10 to 14 days. So that's the kind of key message of this trial. What do you think, Dr. Checo?
Well, one of the other things that might concern us is the relevance of the use of warfarin, because we do use warfarin in at least some of our patients, because cost considerations is a concern with us. And this study obviously does not answer that question. And we all know that the incidence of hemorrhagic complications may be higher with warfarin, and also the fact that it requires monitoring, constant monitoring, and a lot of interactions with the food you eat and things like that, which might actually exacerbate the effect of warfarin. So that's one of the questions that is still unanswered, and especially given the fact that many of our patients still go on warfarin because of cost considerations.
Yeah, that's interesting, because obviously this trial has not answered that particular question, but majority of the places where, I guess, especially in the Western countries or first world countries, the warfarin has probably gone in the background, and then NOACs have become the forefront of this kind of treatment in these patients. So it's interesting. The cost effective analysis of this trial will be quite useful to understand, but that has obviously got significant implication in resource poor settings, as you mentioned. So yeah, that note, Dr. Jaco, thanks for your time. We'll be back in next fortnight to 1 month's time with another episode. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. Until next time, goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.